You spend approximately 8 hours every night in one of four positions: left side, right side, back, or stomach. You chose the position decades ago, probably as a child, and you have defaulted to it every night since without questioning whether it matters. It matters. Your heart, your stomach, your liver, your lungs, your airway, your brain's waste clearance system, and the arteries in your neck are all asymmetrically arranged inside your body. None of them are centered. Gravity acts on all of them for 8 hours, and the direction gravity pulls them depends entirely on which surface you are lying on. Each position produces a different gravitational relationship between your organs and the structures surrounding them. One position wins on more systems than any other. One position damages a structure nobody mentions. And one position, the one most people assume is the safest, is the worst for more than half of all diagnosed sleep apnea. Four positions, one body, four different physics, and the position you default to tonight determines which organs receive protection and which receive additional stress for the next 8 hours. Left side first, because this position wins on three independent systems through three different mechanisms, and the first one involves the largest vein in your body. Inferior vena cava, the vein returning blood from the entire lower body to the heart, runs along the right side of the spine. Left side sleeping avoids compressing it under the weight of the abdominal organs. Right side or supine sleeping can partially compress the IVC, reducing venous return and cardiac preload. During pregnancy, fetal weight on the IVC in the supine position can reduce maternal cardiac output by up to 25%, which is why left side sleeping is specifically recommended for pregnant women. The recommendation applies beyond pregnancy. Left side sleeping provides optimal IVC patency and therefore optimal venous return in every adult. Heart itself sits slightly left of center in the chest, resting in the cardiac notch of the left lung. On the left side, gravity assists its natural anatomical position. On the right side, the heart shifts across the mediastinum, a displacement that is insignificant in healthy individuals but detectable in patients with cardiomegaly or heart failure, who sometimes report palpitation awareness and discomfort when the enlarged heart shifts against gravity. Thoracic duct, the body's largest lymphatic vessel, collecting lymph from 3/4 of the body, empties into the left subclavian vein at its junction with the left internal jugular. Left side sleeping aligns this drainage point with gravitational assistance. The lymphatic return flows downhill into the venous system. Right side sleeping routes the final lymphatic delivery against a less favorable hydrostatic gradient. Two fluid systems, venous and lymphatic, both benefiting from the same gravitational direction. If you wake in the night feeling short of breath while lying on your back, the breathlessness may be partial IVC compression reducing venous return and cardiac output. Rolling to the left side removes the compression. The issue was vascular geometry, not the lungs. Stomach next, the acid reflux physics is geometry that a position change solves faster than medication. Your stomach curves from left to right, with the greater curvature on the left and the esophageal gastric junction positioned on the right side of the stomach's superior surface. On the left side, gastric contents, food, acid, digestive enzymes pool in the greater curvature, which becomes the lowest point. The esophageal junction sits above the pool. Gravity keeps acid away from the junction. The lower oesophageal sphincter is dry. On the right side, the geometry inverts. The greater curvature is now the highest point. Gastric contents pool toward the esophageal junction, which sits at or below the gastric pool. Acid bathes the sphincter. If the sphincter is even slightly incompetent, common in adults over 50 with any degree of gastroesophageal reflux, acid crosses into the esophagus. Reflux episodes were significantly more frequent and more prolonged in the right lateral position compared to the left, as Cowrie and colleagues documented in the American Journal of Gastroenterology. Same person, same stomach, same acid, different geometry. The position determined whether the acid reached the esophagus. If you experience nighttime acid reflux, the burning that wakes you at 2 in the morning, the sour taste, the morning hoarseness, and you sleep on the right side or on the back, the problem is geometry before it is a sphincter problem. Left side sleeping places the acid below the junction. The burning may resolve without medication because the acid never reaches the sphincter when gravity pulls it the other direction. Brain waste clearance comes next. This mechanism was unknown until 2012, and the stakes are neurodegeneration. The glymphatic waste clearance, The sleep timing discussion describes cerebrospinal fluid flushing amyloid beta through perivascular channels that open during sleep operates with different efficiency depending on position. The balance between amyloid beta production during waking hours and clearance during sleep determines whether the protein accumulates over decades, and the clearance rate depends, in part, on which direction the body is lying. Glymphatic transport was most efficient in the lateral sleeping position, as Lee and colleagues documented in the Journal of Neuroscience in 2015. Both lateral positions significantly outperform supine and prone in a rodent model. The brain clears its waste most effectively when you sleep on your side. Back sleeping and stomach sleeping produce slower clearance of the proteins that accumulate in neurodegenerative disease. Mechanism is fluid dynamics. In the lateral position, gravity assists drainage of cerebrospinal fluid through the internal jugular veins. The veins that drain blood and CSF from the brain are oriented favorably when the body is horizontal and lateral. In the supine position, the jugular veins are partially compressed by the weight of the neck structures above them, and the drainage pathway is less efficient. If you have a family history of Alzheimer's and have been told to do crossword puzzles and eat blueberries, nobody has mentioned that your sleeping position affects how efficiently your brain clears the protein that causes the disease. 8 hours per night, 365 nights per year, decades of waste clearance that runs at higher capacity on the side than on the back. The position determines whether the brain's cleaning system operates at full flow or at partial flow every night for the rest of your life. Intracranial pressure adds a second brain-relevant dimension to the position calculation. Supine sleeping elevates intracranial pressure compared to lateral. The hydrostatic physics is straightforward. Lying flat with the head at heart level produces higher venous pressure in the cranial vault than lying with the head slightly elevated by a pillow in the lateral position. The elevated pressure is clinically relevant through two pathways. Intraocular pressure, the fluid pressure inside the eye, rises during supine sleep, and the elevation is a documented risk factor for normal tension glaucoma progression, the form of glaucoma where optic nerve damage occurs despite apparently normal daytime pressure readings. The damage occurs at night, during the hours of elevated IOP that supine sleeping produces and lateral sleeping reduces. For anyone with a glaucoma diagnosis or family history, sleeping position is a modifiable risk factor that ophthalmology appointments rarely mention. Second pathway is idiopathic intracranial hypertension, elevated brain pressure, without an identifiable structural cause, which produces chronic headache, visual disturbance, and papilloedema. Lateral sleeping reduces the baseline intracranial pressure the brain operates under during the 8 hours when the body is horizontal and the hydrostatic gradients are most relevant. That clearance system perivascular channels flushing amyloid beta through cerebrospinal fluid flow that depends on position, intracranial pressure that rises or falls based on which surface the head rests on, both running for 8 hours in whichever direction the body was placed, is the reason the pillow moved to the left side of the bed and has not moved back. You now know the three systems that left side sleeping protects: cardiac return, gastric acid geometry, and glymphatic brain clearance. The question changes: what does the right side offer that justifies the trade-offs, and when does the trade-off calculation favor it? Well, the right side, because it has specific advantages that matter for specific conditions. Liver weighing approximately 1.5 kilograms sits in the right upper quadrant, supported by the rib cage when lying on the right. On the left side, the liver hangs from its ligamentous attachments and pulls downward on the diaphragm. In individuals with hepatomegaly, enlarged liver from fatty liver disease, hepatitis, or congestion, this pull produces discomfort and a sensation of heaviness. Right-side sleeping supports the liver's weight on the rib cage rather than suspending it from ligaments. Some research suggests right-side sleeping produces higher vagal tone measured as lower resting heart rate and higher heart rate variability, possibly through altered pressure dynamics on the right vagus nerve as it courses through the mediastinum. The data is mixed, but the direction is consistent. Heart rate tends to be slightly lower on the right side than on the left. Lung ventilation perfusion physics adds a dimension that matters for anyone with unilateral lung disease. When lying on the right side, the larger right lung, 3 lobes, is the dependent lung, and gravity directs more blood flow to it. Pulmonologists sometimes specify sleeping position based on this physics, Sleeping with the healthy lung down in the dependent position improves oxygenation because perfusion is directed to the better ventilated tissue. Trade-off that overrides these advantages for most people over 50, the gastric reflux geometry. The right side places acid against the esophageal sphincter. For the 20 to 40% of adults over 50 with some degree of reflux, the right side's vagal and hepatic advantages are outweighed by the reflux worsening. The right side is better for the liver and possibly the vagus worse for the oesophagus. The decision depends on which condition is present and which is more consequential. Side sleeping either side produces a cost that the back avoids: shoulder compression. The dependent shoulder bears a significant portion of body weight for 8 hours. The subacromial space, the gap between the acromion and the rotator cuff tendons, narrows under the sustained compression. For anyone with existing rotator cuff pathology, shoulder impingement, or bursitis, the dependent shoulder position can produce the morning shoulder pain and stiffness that worsens progressively over months. The subacromial space that opens during overhead movement narrows under sustained compression, and 8 hours of compression is a load the joint was never designed to sustain. Practical accommodation: a mattress with enough give to allow the shoulder to sink below the surface level, or a position where the dependent arm is drawn slightly forward so the weight rests on the anterior chest wall and scapula rather than directly on the acromion. The arm forward position redistributes the load from the shoulder joint to the larger surface area of the chest and shoulder blade, reducing the point loading on the subacromial space while preserving the lateral positions. Organ advantages: hip carries a parallel cost. Decades of sleeping on the same side loads the dependent hip's greater trochanter against the mattress for 8 hours nightly. The bursa between the trochanter and the iliotibial band sustains chronic compressive loading that a few hours of daytime activity cannot offset. Trochanteric bursitis, the lateral hip pain that presents as deep aching on one side only, is significantly more common on the habitual sleeping side. If you have been told you have hip bursitis and you sleep on that same hip every night, the position is sustaining the condition the physician is treating. Alternating between left and right side, spending the first half of the night on the left for the organ advantages, the second half on the right to unload the dependent hip, distributes the compressive cost while preserving the glymphatic and gastric benefits during the slow wave hours that matter most. Partners who share a bed introduce a variable the individual physics does not account for. The partner who snores produces acoustic energy at 60 to 90 decibels, equivalent to a vacuum cleaner for up to 8 hours. The sleep fragmentation this produces in the non-snoring partner is documented: reduced slow-wave sleep, increased arousals, impaired glymphatic clearance from the interrupted sleep architecture. The consequences extend beyond fatigue. Bed partners of untreated sleep apnea patients show elevated nocturnal blood pressure, increased morning cortisol, and measurably higher cardiovascular risk compared to partners of non-snorers. The non-snoring partner's health is being degraded by the acoustic environment the snoring partner's supine position created, turning the snoring partner from back to side. Reducing the 56% positional component protects both sleepers simultaneously. The snorer's airway opens and the partner's sleep architecture, blood pressure, and cortisol regulation restore. And then the back, because this position contains the most dangerous trade-off in sleep medicine. Supine sleeping provides the most neutral spinal alignment: no lateral bending, no rotational stress, no asymmetric disc loading. The weight of the body distributes across the full posterior surface. For anyone with degenerative disc disease, facet joint arthropathy, or chronic back pain that worsens in lateral positions, supine may be the least symptomatic position for the spine. Against this spinal advantage, the back is the worst position for airway patency. Gravity pulls the tongue and soft palate posteriorly, narrowing the pharyngeal space. The snoring discussion described how the narrowing initiates a Bernoulli feedback loop that can collapse the airway completely. Approximately 56% of all diagnosed obstructive sleep apnea is positional, meaning the obstruction occurs predominantly or exclusively in the supine position. A finding Ravesluit's meta-analysis quantified across the sleep apnea literature. More than half of all sleep apnea is caused by sleeping on the back. The airway that is adequate on the side collapses on the back because the gravitational vector on the tongue changes by 90 degrees. Trade-off is genuine. The position that is best for the spine is worst for the airway. Anyone with both back pain and sleep-disordered breathing faces a real conflict, and the resolution is usually side sleeping with a pillow between the knees to maintain spinal alignment while preserving airway patency. The pillow converts side sleeping from a spinal compromise into a near equivalent of supine lateral position with neutral alignment. Snoring only on the back with a partner confirming that turning you on your side stops it means positional sleep apnea. You are among the 56%. The intervention is a position change, and the airway that collapses when gravity pulls the tongue backward opens when gravity pulls the tongue sideways. Now the stomach, because this position has one genuine advantage and two costs that compound across decades in the 55-plus demographic. Prone sleeping is the best position for airway patency. Gravity pulls the tongue and soft palate forward, away from the posterior pharyngeal wall. The pharynx opens rather than narrows. Snoring and obstructive apnea events are least frequent prone. For anyone with severe positional apnea who cannot tolerate CPAP and whose obstruction is supine dominant, prone sleeping may eliminate the obstruction. The first cost, cervical rotation. Prone sleeping requires turning the head 90 degrees to one side to breathe. This rotation is sustained for hours. The cervical facet joints on the compressed side experience sustained compressive force at an angle the joint was designed for transiently. The muscles on the stretched side, the scalenes, the sternocleidomastoid, the levator scapulae, are held at maximum length under passive tension for hours. The asymmetric loading produces the morning cervical stiffness and pain that gets attributed to sleeping wrong without recognizing that the position itself is the problem. Deeper risk. The vertebral arteries pass through the transverse foramina of the cervical vertebrae bony tunnels in the neck that the arteries thread through on their way to the brain. Sustained 90-degree cervical rotation narrows the foramen on the compressed side, reducing blood flow through that artery. In most individuals, the opposite vertebral artery compensates, but in individuals with atherosclerosis, arterial anomalies, or pre-existing vertebral artery narrowing conditions that become more common after 50, sustained rotation under load is a documented risk factor for vertebral artery dissection, as Chung and colleagues established. The risk per night is low. The risk compounded across decades of habitual prone sleeping in a population with increasing atherosclerotic burden warrants attention. Thoracic cost is additional. Prone position compresses the chest against the mattress, restricting diaphragmatic excursion and increasing the work of breathing. Tidal volume is reduced. The heart is compressed between the sternum and the spine. Modified three-quarter prone body angle between prone and lateral. One leg drawn up. Head rotation reduced to 45 degrees rather than 90. Provides partial airway benefit with substantially reduced cervical rotation. The compromise preserves most of the tongue forward advantage while halving the arterial compression. And then, why position matters more after 45? Because three age-related changes compound the stakes. Glymphatic efficiency declines with age, the perivascular channels narrow, the glial cell shrinkage during sleep becomes less complete, and the cerebrospinal fluid flow rate decreases. The brain's waste clearance, that was robust at 30, is measurably slower at 60. The position that maximizes the remaining clearance capacity, lateral, becomes proportionally more important as the baseline capacity declines. Lower oesophageal sphincter competence declines. With age, the smooth muscle tone that keeps the sphincter closed weakens. The sphincter that held acid in the stomach at 30 begins leaking at 55. The position that keeps acid below the sphincter left side becomes the difference between reflux and no reflux, a distinction that mattered less when the sphincter was strong enough to hold regardless of position. Pharyngeal muscle tone declines with age. The genioglossus and tensor palatini that hold the airway open during sleep lose strength. The airway that was adequate, supine at 30, collapses supine at 60. The 56% of sleep apnea that is positional becomes more prevalent because the muscles that compensated for the gravitational tongue fall can no longer maintain the airway against the force. Nocturnal blood pressure, dipping, the 10 to 20% drop in blood pressure during sleep that protects the cardiovascular system, is position dependent in individuals with heart failure or resistant hypertension. Supine sleeping can blunt the dipping pattern through IVC compression, reducing cardiac output and triggering compensatory sympathetic activation. Left lateral sleeping optimizes venous return and reduces cardiac workload, supporting the full dip. For the high proportion of adults over 55 on antihypertensive medication, the sleeping position is interacting with the pharmacology every night, either supporting or undermining the blood pressure reduction the medication was prescribed to achieve. Every age-related decline makes the wrong position more costly and the right position more protective. At 30, any position works with minimal consequence. At 60, the position is a nightly decision about which systems receive protection and which receive additional stress, and the decision runs for 8 hours every night. Sleep architecture interacts with position in ways that explain why you may shift during the night without it being a problem. Deep, slow-wave sleep predominates in the first 3 to 4 hours, the period when glymphatic clearance is most active and lateral position matters most. REM sleep predominates in the second half of the night, when muscle atonia makes position maintenance less conscious and natural shifting occurs. Starting the night on the left side captures the deepest slow-wave hours in the position that maximizes glymphatic clearance. Shifting to other positions in the second half when the brain has already completed its most intensive waste clearance cycle carries less consequence. The first 3 hours in the correct position matter more than maintaining it for all 8. Nasal breathing interacts with position through a mechanism most side sleepers have noticed without understanding. When lying on one side, the dependent nostril, the one closer to the pillow, tends to congest, while the upper nostril opens. This is the nasal cycle, alternating congestion and decongestion between the two nostrils, driven by autonomic regulation of the nasal turbinate blood flow. The cycle operates continuously, but gravity amplifies it in the lateral position, directing more blood to the dependent turbinate and swelling it. Rolling to the other side reverses the congestion pattern within minutes. The natural position shifts that occur during sleep may partly serve this nasal cycle. The body turns when one nostril becomes sufficiently congested, opening the congested side and allowing bilateral nasal breathing to continue through the night without oral bypass. Temperature regulation interacts with position through the core temperature mechanism. The body must shed heat through the skin to drop core temperature for sleep onset. Supine sleeping exposes the maximum posterior surface area to the mattress, which traps heat against the body through the insulating effect of the mattress material. Side sleeping reduces the body mattress contact area, allowing more heat to dissipate from the exposed upper surface into the cooler room air. Prone sleeping traps heat against the anterior torso and compresses the chest against a warm surface, the worst position for heat dissipation. For anyone who runs warm at night, waking hot, pushing covers off, disrupted by temperature, the lateral position provides the most favorable thermal environment because it balances contact surface insulation with exposed surface dissipation. The position you have slept in for decades can be changed, but the transition requires understanding why the body resists. Sleep position is a deeply ingrained motor habit, maintained by proprioceptive memory. The nervous system associates the habitual position with sleep onset, and unfamiliar positions trigger a low-level alertness that delays the transition. The body is not choosing the healthiest position, it is choosing the most familiar one. Transition training follows the principle of any habit change: gradual replacement with environmental support. A body pillow along the back prevents unconscious rolling to supine during the night. A tennis ball sewn into the back of the sleep shirt produces mild discomfort in the supine position, enough to trigger a position change without full waking. Starting the night in the target position, even if you shift during sleep trains, the proprioceptive association between the new position and sleep onset. First 3 nights are the hardest because the proprioceptive system is sending a low-level alert that the position is unfamiliar, the same neural resistance that makes any new movement pattern feel awkward before it becomes automatic. By night 4 or 5, the alert diminishes. By week 2, the new position begins associating with sleep onset rather than competing with it. By week 3, most people who commit to the transition report that the left side feels natural. The proprioceptive memory has overwritten. The body that spent decades defaulting to supine now defaults to lateral, and the organ physics changes direction permanently. That calculation: 3 systems protected on the left, the airway opened on the side, the brain's waste clearance running at its highest available rate, through channels that narrow with every year, the acid held below a sphincter that weakens with every decade, is what I weigh every night when the position is chosen, and the physics begins running for the next 8 hours. Left side for most people over 50. Cardiac return optimized through IVC decompression, gastric reflux minimized through acid below sphincter geometry, glymphatic brain waste clearance running at its highest available efficiency. Right side if hepatomegaly makes left side sleeping uncomfortable, or unilateral left lung disease requires the healthier right lung in the dependent position. Back if chronic back pain requires neutral spinal alignment and no sleep disordered breathing is present, but if you snore on your back, you are in the 56% and the position should change. Stomach. Avoid unless severe positional apnea is unresponsive to lateral sleeping and transition to modified three-quarter prone to reduce the cervical rotation that compounds across decades. A pillow between the knees for side sleeping maintains pelvic and spinal alignment, preventing the top leg from pulling the pelvis into rotation and loading the lumbar spine asymmetrically. A pillow that supports but does not elevate the head maintains cervical neutral in lateral position. Both convert side sleeping from a postural compromise into a spinal near equivalent of supine with the organ advantages supine cannot provide. Direction that protects the most systems for the longest: the acid below the sphincter, the vena cava uncompressed, the brain's cleaning system running at full capacity through channels that narrow with every year is the direction the organ geometry was asking for the entire time.